Next topic is infectious disease. We have an infectious disease specialist, Dr. Pierre Tatavin. He's going to be talking about managing COVID-19 patients actually outside of the intensive care unit on the wards and potentially in the community setting. Dr. Pierre?
Do you hear me now?
Yes.
Okay. So hello, everybody. I'm Pierre again. It's a very common name in France. I'm a specialist in infectious disease, and I used to work in ICU until last year when I turned 50, but now I only work in the infectious disease department, so I will mostly talk about the COVID-19 outside of the ICU. So I know the time is short, so I try to put on my slides the most important messages that I think are important from from our perspective here in France. So maybe the first one is really a red line, is that we have to be aware that many other diseases are still ongoing in our community, and the COVID-19 outbreak should by no means be a loss of opportunity for these other diseases. And we have very good signs that there have been some loss of opportunity for some disease. For example, myocardial infarction diagnosis has declined last month in France. And it's probably not because there have been less myocardial infarction, but it's probably because the patient did not come to the hospital to get treated. And the same for active TB, for example, that decreased significantly last month in France. And it's just diagnoses that were not made and that we will probably diagnose too late. So one very important point is that every hospital, every doctor, every health system must implement a system that will still take care of the other emergency, even in the big wave of the COVID-19. So the second basic principles that I think is very important to keep in mind too is that all the studies that have been done everywhere in the world with this outbreak is that more than 85% of patients will just get cured with no medical intervention. And it's very important to keep it in mind when we will be talking about the treatment that you can give to patients. And for example, in France, there has been a big polemic about the benefit of hydroxychloroquine, which is administered to patients with lupus usually. And there have been very bad communication with this drug. And following this, some patients with absolutely no indication for treatment took it with no medical overview. And we have been at least 5 people who died because of taking this drug because they saw at the TV or in the media that it was a good drug for COVID-19. So the second message would be not taking any risk with this disease in most patients. They will be fine just waiting for 1 or 2 weeks that the virus will get cured by itself. And the second point, but this you all know because we would not have a big wave in every country if it was not highly transmissible. So it is highly transmissible, probably not only by the droplets, probably also by contact. So we have to be very effective in terms of infection control and hygiene, but it has been very nicely said by Juliette already. The third message is that the paradigm are changing almost every week. So we have to prepare when we do communication about the COVID-19 that what we are saying now may not be what we will be saying in 2 weeks. So we have to be cautious about the messages, and it has been a big problem in France. So for example, the rules for PPE were quite different at the beginning when we didn't know exactly how it is transmitted. And we used to promote the N95 for any patient by the beginning. And in terms of communication, it's quite complicated when you have to explain a few weeks later that finally you don't need N95 mask for everybody. So we have to be humble about what we know about this epidemic. And it will remain the case probably even in the US a few weeks later, because this disease brings a lot of surprise. My fourth message is it's more organizational, but it's something that we have to keep in mind too, is patients should not be moved unnecessarily. And to give you an example, when we had to take care of the first patient, the rule was to have it admitted in a very referral center. So we used to move patients from the peripheral hospital to the tertiary care hospital because it could make sense by that time. We didn't have a lot of patients and we had the resources to move the patient. But after, when the number of patients is too high, and I know it's already the case in all states in the US, just keep the patient where he is, except if there will be some concrete gain for him if he's moved to a referral center where the ICU maybe will be better. But otherwise, it's better to leave the patient where he is when he's diagnosed with COVID-19. And it also applies for the long-term care facility, for example. Most of the patients with COVID-19 in our long-term care facility remained there during their disease, and probably it was beneficial. My fifth messages would be about the day 7, day 10 window. You probably will hear more about that on the immunological talk, but it's true that we saw patients that look fine until day 7, and then they worsen quite fast. Sometimes unexpectedly, they were not old, they were not with a big comorbid condition. So the message here is that you can leave the patient at home with COVID-19 if he has no signs that is bad, but you have to be alert and to change your opinion very fast. If you receive a news from his general practitioner or for the patient himself that is not fine at day 7, day 8, day 9, you have to see him fast and to plan admission in the hospital for any kind of symptoms you can have within this day 7, day 10 window, because it may be a chest pain, it may be a breath, shortness of breath, it may be high fever, but whatever happens in this window is something that you should be alert. And finally, but you probably all know about that, we are changing our opinion many times with this virus, so be ready to do that. Next slide, please. So regarding the anti-infective treatment, I can be fast on that because after 2 months of seeing patients in France, and I exchanged with the sites that saw a lot of patients, like in the eastern part of France or in Paris, and we still have absolutely no clue about what could be the anti-infective treatment that will be efficient for this virus. So I put you there the treatment that has been most evaluated. One was hydroxychloroquine or chloroquine, and that support its use. We know that some patients died because of this. And there is a paper, I put you the reference, it comes from the US, where they could compare the evolution of patients who receive it and comparable patients who did not receive the hydroxychloroquine, and that even suggests that it's worse when you receive hydroxychloroquine than when you don't receive it. So really be cautious and don't apply what we have been doing at the beginning to say it's better to give that than nothing. We even don't know that. Sometimes it's probably better to give nothing. The second drug that has been used because it's interesting in vitro is the lopinavir-ritonavir combination, either alone or associated with immunomodulation, immunostimulation by interferon beta, who has some efficacy on the virus in vitro, both. But regarding lopinavir-ritonavir, you're probably aware that there have been a big randomized trial with 100 patients in each arm that saw no real benefit, even on virological endpoints. It doesn't mean that it's bad, because in this trial they use it very late, but it keeps us cautious. The third drug is remdesivir, that is almost not available in France except for compassionate use in pregnant women. So I have not much to say about that. It's interesting in vitro. And there is one publication about compassionate use, but we really don't know if it works. Same about plasma from convalescent, from patients who were cured from COVID and that can be used and that currently evaluated in a few clinical trials. Regarding the antibacterial treatment, what we have been recommending in France, we have guidelines about that. If it's non-severe and you think it could be community-acquired pneumonia, we give either amoxicillin clavulanic acid when it looks like pneumococcus, and the main clue is when they got a sputum, purulent sputum. Or the second antibiotic that we can give is azithromycin, because there have been some co-infection with Mycoplasma pneumonia, for example. And when they are severe, we have guidelines in France for any kind of severe community-acquired pneumonia that give third-generation cephalosporin plus macrolides to cover also legionellosis. And regarding the management of chronic treatment, the main message is that the patient can keep all their treatment, their chronic treatment, including ACE inhibitors or even immunomodulating agents during the COVID-19 outbreaks. The only caution we have is not to use non-steroidal anti-inflammatory drugs in patients who don't have it by the time of their COVID-19. And my last slide, please, just to show you what is the biggest hope we have in terms of anti-infective treatment. This is the guidelines that have been proposed at the WHO. It's called the Solidarity Clinical Trial. It's a template so that we use the best option in our clinical trials. So it's what they call adaptive clinical trial. It means that if after a few weeks we realize that one of the arm is bad, it will just be stopped and the rest of the trial will go on. And on the other hand, if a new drug appears and look promising, they could add a new arm in the trial. And currently we are trying to enroll as much patient as we can in this trial. So we have 5 arms, the drugs I talked to you about, and 1 arm that is standard of care. And until now we have enrolled 650 patients in France. So it's not a lot compared to the 100,000 patients that we had, but we will have probably result by the end of April that may help us to know what is the best treatment among this list of the most promising anti-infective treatment. And I thank you for your attention.